So, good morning to you all. I want to thank Dr. Sava Surmelis and Professor Olga Savidou for the kind invitation. And let's go ahead with our topic. The common causes of elbow injuries in athletes are first insufficient warm-up, insufficient cool-down, insufficient rest, poor training and sport technique, poor condition of the athlete. Be careful with the fourth, poor training and sport technique. Don't forget that young athletes are very enthusiastic, and their trainers also, and their parents also. And this enthusiastic, let's say, practice of these young athletes leads to a high incidence of injuries all over the body, and here we are going to discuss everything which has to do with the elbow. So the entities we are going to discuss are the triceps rupture or with or without olecranon avulsion, the olecranon impingement syndrome or hyperextension valgus overload syndrome, the boxer's elbow, as we said, ossification of the posterior capitulum. This is also a variation of the boxer's elbow, so avoid to box with your wife or with your man or whatever. Olecranon stress fracture, olecranon bursitis, the miner's elbow or student's elbow, and then fractures of the radial head, ulna, and medial epicondyle. Concerning triceps rupture or traumatic olecranon avulsion, this is an entity which happens when the athlete falls on the outstretched hand, and then you have a contraction of the triceps, so that means that you might have an avulsion fracture of the triceps, or you might have a rupture from the triceps, of the triceps to the olecranon. This is a very rare injury associated with steroid use, metabolic bone disorders, and renal failure. The physical examination shows tenderness, swelling, hematoma, weak extension or no extension at all, and of course a palpable defect. And then the diagnostics are the clinical radiological flake sign, bone avulsion from the olecranon, and with the MRI you can see and diagnose the rupture of the triceps. The treatment might be conservative, with a splint immobilization in slight flexion, 20 or 30 degrees, for 4 weeks, especially in partial tears. But the real treatment here is operative. This is the treatment of choice, and you can suture it, you can fix the avulsed bone, and the prognosis and return to play is very good with 6 months of recovery. That means the athlete can go back to sports in about 6 to 7 months. The olecranon impingement syndrome or hyperextension valgus overload syndrome or boxer's elbow is an entity where the olecranon process bumps onto the posterior and medial soft tissues of the olecranon fossa, and this happens to boxers, football linemen, gymnasts, and weightlifters. The symptoms is the posteromedial elbow pain, especially in extension with a crepitus, or a catching feeling, a blockade in the elbow joint, loss of velocity and missing high in throwers, and loss of control. Clinical findings is the loss of final extension, posterior elbow pain with valgus, and possible laxity of the ulnar collateral ligament. The radiographs can show loose bodies, hypertrophic bone formation around the fossa, especially at the posteromedial area, and we use also MRI for evaluation of the cartilage. The treatment might be conservative with protection, rest, ice, compression, elevation, physiotherapy for improvement of motion, and strength of flexor and extensors. The operative treatment is the removal of this osteophyte, the cleaning of the fossa, And if indicated, we should do ulnar collateral ligament reconstruction. 80% of these people return to play. We must be very careful if we do especially arthroscopy in this point so that we don't remove a lot of the posterior medial osteophyte. We might lead to elbow instability. Ossification of the posterior capitulum is another entity which has as main cause boxing, and this is abnormal bone formation on the posterolateral aspect of the elbow at the capitulum. This happens in handball, goalkeepers, boxers, and the dominant arm is affected. What we have here is posterolateral elbow pain in extension. This is the origin of the anconeus muscle, restriction of extension about 7 degrees. And of course, in the clinical examination, we have tenderness in palpation. This is the imaging. In the X-rays, you can see the ossification. In the computer tomography, you can see the osteophytes. And in the MRI tomography, you can see this bone edema and, of course, cartilage lesions and the osteophytes also. The treatment is operative. You can do either an arthroscopic or an open excision of the osteophyte. The olecranon stress fracture is another rare entity here. It happens to baseball players in about 80%. The rate is about 80%. In javelin throwers in about 7%. And the rest in Sosa players, football players, softball players. We should think here of on the epiphyseal non-union. We might be confused if this is a fracture or if this is the epiphyseal, a delay in the epiphyseal union. And the mean age of this injury is 20 years. The mechanism is that this is an overuse injury in gymnasts and throwing athletes. 58% of all stress fractures. This is, let's say, the commonest of sport injuries in the elbow, with symptoms, pain in the posterior or lateral elbow during the acceleration phase of throwing. Clinical findings, tenderness at the olecranon process, and insufficiency of the medial collateral ligament. This could be a finding or not. The olecranon stress fracture should be differently diagnosed from triceps tendinitis, olecranon bursitis, posterior impingement syndrome. And if we need a further diagnosis, we should do the CT scan and the MRI or bone scan. The treatment could be conservative, no sport activities, no weight lifting, just wait for 2-3 months with the elbow immobilized for 4 to 6 weeks in slight flexion, 10 to 20 degrees of flexion. The problem is that we have a high rate of failure with a conservative treatment, about 30%. And so we usually proceed with the operative treatment, and we do this if the patient remains symptomatic, and we do it with screw plate fixation. This is the best way to fix these stress fractures, and if needed, reconstruction of the ulnar collateral ligament. The bursitis is a common entity. I think most of us have seen 2 or 3 cases of olecranon bursitis. And this is the inflammation of the bursa overlying the olecranon process. The mechanism could be direct trauma to the posterior elbow, a single blow, or repetitive trauma. And this happens in football and hockey players. The symptoms is swelling, pain, sometimes with infection symptoms also. And sometimes we find signs of infection such as heat and huge swelling, and sometimes we see also wounds around the elbow. And the differential diagnosis should be from gut, calcium pyrophosphate deposition, and diagnostics we do with X-rays. We can see calcification of the bursa or an olecranon spur, and in some cases we should aspirate the bursa and send cultures. Especially if we have a wound around the elbow, this should be done. The treatment is price and drugs. We could aspirate this bursa and inject corticosteroids. And if this is septic, of course, we could exist the bursa and give antibiotics. In chronic aseptic situations, we also have to do excision of the bursa. The fracture of the radial head is the cause of this situation, of this entirety, is to fall on the forearm with the elbow in about 80 degrees of flexion. This happens in male athletes, and the most common fracture is the Mason 1 type. The treatment in Mason 1 types, we do conservative treatment, and in Mason 2, if we have a huge displacement, huge is more than 2 millimeters here, and if the elbow is unstable, we do reduction in internal fixation. Mason 3 and 4 should be operated. I would say forget in athletes the head replacement. We should do just internal fixation and ligament repair. The material which we use in these cases should be minimal. Ulnar or leg canal fractures are very, very rare in athletes. The cause is a direct impact to the elbow, and the treatment is operative. Most recommended here is the plate fixation, as in the stress fracture. And the medial epicondyle, fractures of the medial epicondyle, medial epicondyle is the last ossification center of the elbow, and it's a very, very important point for throwing athletes and arm wrestling. Here, high forces from flexors and pronator are applied in about 90 degrees of flexion and cause this fracture, which could be acute or stress fracture. The treatment, if the displacement is huge, 2 to 5 millimeters, we treat it, if it's between 2 and 5 millimeters, we treat it conservatively with immobilization in 90 degrees of flexion for 2 to 3 weeks, and then an orthosis for 6 weeks. But if the displacement is huge, more than 5 millimeters, and if the fragment is rotated, if we have instability, or if the elbow is blocked by fragments, or if the nerve has a dysfunction, then we should operate with and do cannulated screw fixation and, of course, repair of the medial collateral ligament. Thank you very much.